in terms of dealing with your patients, your cardiovascular patients, adherence to medication is so important. I'm just wondering if you could share with us what is your strategy, if you will, around empowering patients to stay adherent to the medication. I know back when I was in school, it may have been a little bit longer than you, but they told us not to say compliance because compliance meant as if the patient was being, like they're not compliant with me. And so,
No, we got the exact same lecture.
yeah. So, what just share with us some strategies that you use to help motivate your patients to stay adherent.
Yeah, this is actually my favorite part of this whole discussion because I think this is where you start to really think about the person in front of you, think about what motivates them, what's their style. Some patients are just tell me what to put it on a checklist, I'm gonna do it, that's fine, move on to my taxes or whatever else. Other patients want much more, control and want to think about it. And other patients still want to understand how the medication works almost on as deep of a level as you do. And so I think one is trying to think about who's in front of you and how much information they want on what you're asking them to do. I think another part is, I won't, use the term like gamification. And by that, I mean, it's a little bit of an abuse of the word, but by that, I mean, sometimes we order tests because we want to make a diagnosis. And we know that we're going to make a different decision based on the diagnosis. Other times, like in this example I'm giving you, I think there is value for tests if there's not a lot of exposure to the patient in terms of radiation or risk of harm, et cetera, where we might order something like a cholesterol panel, for example, just to measure progress, right? We know you need, I feel strongly that you need these 2 or more cholesterol-lowering medications and the aspirin, but maybe it's helpful for you to kind of self-motivate and say, hey, yes, I did that thing. I've seen my LDL cholesterol go from 160 to, 87, and we're trying to head towards 50. That might be the reason alone to order another lipid panel, even though I know it's not going to change our course. So I think that's one strategy, is allowing kind of some milestones or celebration of checkpoints and what you and the patient are accomplishing. And then another strategy that can sometimes be used, not always, gets back to that autonomy piece. And the spin on autonomy this time I'm talking about is maybe there's a medication that is helpful for your symptoms, but the way you take it can be left up to you. Maybe it doesn't have to be taken all the time. Maybe it can be taken just before exercise, or maybe you've noticed that it gives you this side effect, and so you would rather take it at before you eat or at nighttime. And so that's one strategy I use with some of my patients, just to say, hey, you've got 6 medications, and for these 4 or 5, you've got to take them, or you will incur serious harm. But for these 2 others, I want you to try and adjust them yourselves. I'll give you some parameters. I want you to be in communication with me about why you're adjusting them, but feel free to kind of learn how they affect you and kind of figure out where the sweet spot is for yourself. I think that can go a long way with patients feeling kind of empowered that they've got a tool and they have some autonomy, like you said, to know when to use it.
That's a great point. And so in terms of patient adherence, can you touch on the social determinants of health and how that might impact a patient's ability to either not take medication or not stay on the medication?
Some things that come up frequently are their lifestyle in terms of work, whether they're working or they're not. So let's say they are working, but maybe they are a bus driver, or maybe they're a construction worker, maybe somebody who doesn't have regular access to a bathroom. And so as a cardiologist, we use a lot of medications known as diuretics that make patients urinate or pee. And so we might have patients that feel so uncomfortable when we give them something like furosemide or some of its cousins that make them pee, that they don't take it at all, right? And so, but maybe they don't have the flexibility in their job to be able to say, I need to step away, I need to park this bus and use the bathroom. And so you've got to come up with creative strategies, and again, working with the patient to help them figure out when they can adhere best and how we might modify the patient's schedule of medications to kind of adhere to their lifestyle in terms of work or otherwise. I think some other examples are cost of medications, right? Sometimes, we talked about medications and advancements in the practice of medicine earlier. And so you might intuit that, some of the latest and greatest are going to be the most expensive. And we're excited about them because we've seen the benefit. But, that benefit might be incremental. We might have a medication that gives you, let's say it lowers your cholesterol by, and this is a made up example, but let's say it lowers your cholesterol by 30%. And we're super excited about that. But the cheaper medication maybe achieved 20 or 25%, right? In a perfect world, everybody would get the 30%. But for a patient who can't afford it, either due to out-of-pocket costs or lack of insurance coverage, they might be so upset or embarrassed or whatever have you, that they just decide to not take the medication at all. And so I think that's where it comes down to having just an honest discussion about, hey, what are these out-of-pocket costs like? What is the threshold to which we might say, let's go for this cheaper option? Because in many cases, something is better than nothing, but you have to kind of be in tune, the patient and the provider, to know that, hey, this first line option wasn't the right choice, and settle for a second option that's still going to be much better.
What are your thoughts and general strategies around addressing patients who are adverse to taking medicine and want to lean toward a more natural, air quote, treatment modality? And, I always say, listen, I'm all for natural, but sometimes when the horse is already out of the barns, we're behind the eight ball. But as a specialist, and specifically a cardiologist, tell me what are some of your go-to points to get patients to adhere to a more, just a better care and not necessarily lean toward air quote natural?
It kind of comes back to some of that relationship building. But I think one part that I didn't get to mention earlier is honesty, right? If you've got somebody in front of you that is 35 years old and they've already had a major heart attack, they've got a little bit of heart failure, and their baseline LDL is 195, with normal for our listeners or watchers, being in the 90 to 120 range, right? So they're much higher. Then I think you've just got to sit down and be honest and say, hey, I think there's definitely room for lifestyle, and certainly some of these non-traditional remedies or modes of care, but you really are not the average person. And so you really ought to take advantage of medical science in this particular scenario and, take the statin. I'll work with you on the dose. There's plenty of new options. We'll try and make it as affordable and palatable as possible. But I would feel like I would be doing you a disservice if I sat here and didn't try to correct course from where your genetics are, headed. And then there's other cases where it's the opposite, right? You've got somebody with maybe average risk, and they don't want to take the meds, and you think, you could make some incremental improvement on their overall risk. Let's say their overall lifetime risk of cardiovascular disease is, 8%. And you think with meds, you could lower it to 6-7%. Is that worth it? Maybe not, right? And so, you're talking about somebody with average risk who may be going a little bit above average in terms of the medications and medical therapies. Maybe that's not, what they want to do, and that's fine. But I think in certain cases, you got to be really honest. And in other cases, you got to be willing to just say, hey, you know what? I've given you the facts, and that's okay. But then also giving them permission to change their mind. And so I think that's where the time kind of comes in. So you say, hey, we've talked about these things. I'm going to write them down for you. I want you to go home and talk to people that because there's many of your peers that are on these meds, and then read about it. And then you come back in, we'll spend 20 minutes. We'll just talk about it. No commitment to make any changes. So I think that can be a good strategy sometimes. And then the one exception I'll throw in is there are some times, non-traditional therapies or, supplements, because medications are regulated, supplements are not, which is an important distinction. There are sometimes some of these non-traditional things that absolutely cause harm, maybe because of who the patient is, or maybe they're just harmful for everybody. So I think that's kind of a situation where, we as clinicians have a duty to step up and say, hey, you really shouldn't take this thing. It's going to harm you in the long run. And frankly, it's, a waste of money as well. So I think keeping those things in mind helps me kind of decide which battles to pick and how strongly to fight, so to speak.
That is so well said. I want to record that and just play it to my patients when they mention to me about things. And I just want to personally thank you on behalf of MD Newsline, your ability to just explain these cardiovascular topics in such a very plain and simple way is really unmatched. And thank you so much for your time.
Yeah, my pleasure. I hope we can do this again sometime, Dr. Pete.
I absolutely think we will.